Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Tony Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. All right, guys. Well, I'm excited to be here today for another PEM Chat episode. Today, we're going to talk about common orthopedic emergencies. And I'm joined by two guys that I've known a really, really long time, and I'm excited to be here with both of them. First is Dr. Chuck Gomez. He is a pediatric orthopedic surgeon. And second is John Appel, PA. He is one of my colleagues. So thank you guys for being here today.
Yeah, thanks so much for having me.
Yes, ma'am.
Why don't you tell us just a little bit about you, Chuck? Maybe tell them how we know you.
Yeah, so it's kind of interesting, maybe a little boring, but maybe a little poetic. My introduction into healthcare started a long time ago as a tech in the children's ER here in Chattanooga. That's where I met John and Tony when I was really green and inexperienced. I worked as a tech for 6 years. It's where I learned I had to be a pediatric orthopedic surgeon. Went to medical school at University of Tennessee and then did my residency in Southern California and my fellowship at Cincinnati Children's Hospital. I was in practice for 4 years in Georgia and finally had the opportunity to return home to Chattanooga, and I have been in practice here for the last year and a half.
Yeah, it's awesome. We're so glad you're back. We were so excited. We knew Chuck when he was a baby, it feels like. And we get lots of people that come through our department and tell us they're going to go to med school, but we don't believe most of them. But we did believe you. I think you've been in love with...
I don't know if that's true or not.
Well, you've been in love with orthopedics since I knew you back way back when.
I'm going to interject real quick here. I want to, just get this out there. Dr. Gomez is the pediatric orthopedic specialist. I am just someone whose favorite system to deal with in the ER is orthopedics.
Yes.
So I may throw something here and there out, but I'm going to be deferring a lot.
Oh, I don't know. People consider you our resident ortho expert in the ER, John. Give yourself a little bit of credit. John, tell us a little bit about you.
I have been a PA since 1998, and I've been in the children's ER in some capacity or another that whole time. I did leave for private practice, but I still did moonlighting in the ER. And then prior to that, I was a nurse in the children's ER.
Yeah, you've been with us a long time.
When were you in the children's ER, Tony?
Early 2000s.
Okay. It all blends together for me.
I know.
I cannot remember who's come through there.
You were already a PA when I came on.
Okay.
And Jen and Tracy started when I was there. Okay. And I think you, Chuck, started... I was already there and you started.
I started working as a tech in December of 2003.
Okay. Yeah. And then I left and went upstairs and returned home to the promised land. We are all back home. It's good.
Yeah, actually had the opportunity to work with you as a nurse on L&D when I was a medical student.
I don't even remember that.
Yeah, you were in nurse practitioner school, I think. So
okay.
Maybe it was all a blur.
Maybe.
But I remember it because that was one of my least favorite rotations as a medical student.
Well, funny thing, as much as I love OB, I don't love ortho, guys. That's why you're my ortho bros, because this is not my favorite body system by any means.
It's all good. Just send it our way.
I'm leaning on you guys today. I love to ask people just kind of a fun question. What's your favorite thing to take care of?
I love orthopedics. My favorite surgery to do is scoliosis surgery. I love fixing spinal deformities. I like big procedures, and there aren't many other ones in orthopedics that are quite that significantly, I wouldn't say risky, but you're fixing a curve in a patient that's otherwise well. They don't have an injury. Most of them don't have pain or any neurologic conditions, but you're putting screws in millimeters away from the spinal cord. So the stakes are a little bit higher in a patient that has no problems, and you're fixing their spinal deformity. So I like big procedures. I like challenging procedures. And for me, that's fixing a scoliotic curve.
That's awesome. John, what about you?
It's really funny because I'm like the complete opposite. He wants these big, elaborate, time-consuming. I'm like, I love nursemaids' elbows.
Yeah.
The kid comes in, they hate your guts. Parents are all upset and uptight. Boom. 5 seconds later, everyone loves you. You're like a magician.
Yeah.
That's probably my favorite.
I just talked to Dr. Beachjam, and that was her answer too. Yeah. Because we're the savior that comes in and fixes them. It's pretty great.
Patellar dislocations would be in that same kind of vein, just quick fix.
Yeah. Not a big thing to solve, like Chuck Lakes on the other hand here. All right. Well, I thought we would start this podcast, Chuck, with you just talking a little bit about why kids' bones are different than adult bones, because this kind of lends credence to how we treat them a little differently and how all this pathology looks a little differently. So talk to us about why bones are different in kids.
Yeah, so kids have a lot of differences for sure. They're not just little adults. Kids that are growing have open growth plates, and sometimes that means that at certain ages and things like the elbow, even the hand and wrist, sometimes you don't even see the bones that are there because they haven't ossified yet. So that's kind of why we exist as pediatric orthopedic surgeons, is to know kind of what's important and what can just be splinted and watched. So not only are there growth plates to kind of keep in mind, but with growing bones come kind of pattern specific deformities and fracture patterns that you should look for certain mechanisms for you guys like a nursemaid's. So that's kind of in a nutshell the difference. And that's important because if you have a physeal injury that maybe doesn't get treated, it could lead to a growth arrest or an angular deformity that needs to be treated later on down the road.
Yeah, I came from adult to pediatric, and when I first started, I will never forget Lonnie King asking me why I was ordering a wrist film on like a 6-year-old kid. And I was like, because they have wrist pain. And he was like, absolutely not. Don't do that. You're not going to order a wrist film on a kid that's not skeletally mature. And I hadn't really thought that through before. And so that was one of the most valuable pieces of advice I ever got, was thinking about, is this really going to affect the wrist? Probably not, because those bones aren't even touching each other at that point. But I'm looking for something that's probably in the forearm or the hand instead. So what about the fact that kids are more likely to have fractures?
What do you mean?
Or I guess I should start by saying their bones have more cartilage in there and how they're made. They're more plastic.
Yeah.
And you're more likely to have like a fracture than a ligamentous injury.
Yes. Okay. Yeah. Great point. So this is important in kids that are growing when it comes to ankles, because kids in particular, younger kids that have open physes, when they hurt their ankles, they don't have a ton of ankle sprains. Sure, they can get ankle sprains. Older kids that are still growing can get ankle sprains, but younger kids, younger than 10, they don't have your stereotypical ankle sprain because the ligamentous attachments to the bone is really strong. It's stronger than the growth plates. So as we grow, in our long bones, we have growth plates that go from cartilage and then ossify. That's how our bones get longer and wider. And those ligamentous attachments to the bone are super strong. And so when you roll your ankle, a lot of times when you invert your ankle, those ligaments pull, and kind of the weakest spot is maybe the distal fibula physis, which can kind of fracture, and you can get a Salter-Harris 1 fracture. And not necessarily an ankle sprain per se. Older kids that are nearing skeletal maturity, they can get ankle sprains. Adults get ankle sprains because there are no physes. Their bones are solid and the ligament is not as strong. as the attachment to the bone. So it doesn't usually pull or avulse bone because there are no growth plates. It tears the ligaments. So that's kind of the difference in kids.
Yeah, we have this like thing in the people talk about how kids don't get sprains. It's, I guess what we're talking about is like the little bitty kids that come in.
Yeah, I would say younger, like younger than 10. Everyone's a little bit different. In general, girls, they stop growing around 14, boys 16. Not everyone follows all those rules exactly. But younger kids, younger than 10 or 12, I typically, when I see an ankle injury, I kind of treat it like a Salter-Harris 1 fracture. And I err on the side of caution. I'll put them in a boot or a cast, rather than like giving them a lace-up ankle brace or something, because most likely, if clinically they're sore right over their fibula, it's just a non-displaced Salter-Harris 1 fracture.
Mm-hmm. John, what would you say the most common thing we see, as far as fractures go in the ER is?
The forearm fractures, those foosh injuries.
And if you've never heard of the foosh word, what does that mean?
Oh, goodness. Fell on
outstretched hand. Yeah.
I've used the term for so long, it's just synonymous. That's a foosh injury.
Yeah.
I'm not really sure what that means, but that's what it is.
Yeah. Yeah.
And probably the buccal fracture, I would think, is the most common. And because there's such a range on those, we'll like see the tiniest little thing, and then we'll see some that have that, a little bit of displacement. But I think probably a buccal fracture on the forearm is probably our most common thing.
Sure. And so when you're examining a kid with like a forearm fracture, tell me, walk me through your exam.
Well, first thing I was taught a long time ago, important things first, right? So you got to make sure they're neurovascularly intact. What are their pulses like? What's their cap refill? Their sensation? Do they have 4-range of motion of their distal digits? That's the very first thing that I want to knock out of the park, because those are things I cannot miss.
Right. And if they don't have that intact, what changes?
I'm getting on the phone pretty quick with Dr. Gomez or his associates.
Yeah. Ortho's on the way, right?
That's right.
Okay. And then what's next?
So I would, next most common? Is that what you're asking?
No. In your assessment.
Next? Well, little kids, I have found a lot of times there is very little swelling. But if you go down with your finger down their arm, you get to a point where you're pushing, they usually pull away when you get to that spot where there's something wrong. Right?
Mm-hmm, mm-hmm.
So that would be the next thing I would do. And then of course, at that point, if they need pain medicine, you do that, get some x-rays, and then decide at that point, do we need to get orthopedics involved now? Or is this something we can splint and send them to the office?
Yeah. What do you usually choose for pain control initially?
Well, it's interesting. It used to be, we were really a lot more free with opiates back in the day, right? Everyone got a slug of Tylenol with codeine when they came in, even for the tiniest little buccal fracture. I personally have really tried to get away from that, just because of what our country's gone through and what I've seen with my own family members with opiates. I give these kids Tylenol. I've heard, Chuck, that some orthopedists don't like us to use ibuprofen. Is that true?
Yeah, I think in some instances there's this theoretical kind of inhibition of bone healing because of the pathway of some of those anti-inflammatories. But I use, in kids at least, I have not had any issues with fractures not healing, even in some of the larger, more powerful NSAIDs like Tordal. I actually like it quite a bit in my postoperative patients, like supracondylars or even distal radius fractures, and even in my spine patients that are getting fusions, and I have not had any problems or non-unions that I've seen.
I've heard, correct me if I'm wrong, Chuck, but I've heard that ortho is very frequently telling people post-operatively to use a combination of Tylenol and ibuprofen like Q6 hours. Is that?
Yes. I think that's a good thing to do, just to break up some of the scheduling of getting some kind of pain relief. Everyone has kind of their different regimens. I think some people don't like opiates at all in their patients or postoperative patients. I always give my families postoperatively some kind of narcotic pain medicine, just because it can be, significant at night, or they can have pain. So we also give, in surgery, we give blocks. So a lot of people that are not prescribing NSAIDs, narcotics, it's because they have a block from anesthesia, and those typically last anywhere from 18 to 36 hours. So that could be some of the difference, but I don't shy away from the use of high set or narcotics, especially in bigger fractures like tibias or femurs, postoperatively.
And I tend to give, like some intranasal fentanyl or something short acting in the short term, just for manipulation for imaging, or, their initial discomfort until they're splinted.
I was going to say, it depends, right? If we have a kid with an obvious deformity or is in severe pain, yeah, we'll give them a squirt of intranasal Versed. And if it's a kid that has a fracture that's going to have to be reduced and they have an IV, I'll give them some morphine.
Yeah.
I guess I was talking more about your simple buccal fractures, or
kids running around using the arm,
where the parent insists they're in all this pain, but the kid is laughing, and yeah.
Sure.
So.
Okay. What about splinting for these patients, John? Typically, if we're talking about like a distal radius, a buccal fracture, or just something that's minimally displaced, we're not having to reduce it. How do you typically splint that?
I remember when it used to be every kid got like a sugar tong for that. I think that's a little overkill. I use a lot of the Velcro forearm splints for that kind of thing, because it's just easier for everybody involved.
Yeah. And if you don't have that, like if you are at an office that doesn't have a limited supply of pre-made splints, but you could do something plaster, what would you pick?
For a typical forearm fracture?
Yeah.
Probably a sugar tong, I would think. Depending, you could also do a volar splint for a few of these things, but correct me if I'm wrong, sugar tong pretty much covers most of everything in the forearm.
I like the sugar tong.
Yeah, if it's really minimal, I typically do like a volar, and use sugar tong in other applications for forearm fractures. What were you going to say?
Oh, I like sugar tong splints because, if it's a distal radius and they're swollen or painful, I think a volar wrist splint or something like that is fine. If it's more of like a forearm shaft fracture, then I like a sugar tong, because I want to control the rotation of the forearm. And so whenever you involve the elbow, they can't supinate and pronate. And so if you have a fracture that is maybe gonna displace a little bit, just controlling supination and pronation and including the elbow is the best.
Okay. Yeah. Good advice.
Since a lot of your audience is going to be people in kind of acute care clinics and things, APPs that don't have a ton of experience with ortho. I remember one of our attendings years ago, who you guys both know, and I won't say the name, but one of his theories was, you're never going to get sued for splinting somebody. So his theory was, if you don't know what to do, but they're neurovascularly intact, otherwise fine, put them in plaster and send them to an orthopedist.
Yeah.
Don't just say, I'm not really sure what to do here. Well, let's just not do anything. That's never the right answer.
I think when you don't work in peds and you're from the outside looking in, it almost looks like we over-treat orthopedic injuries in children. And I don't think I really had a real clear appreciation of why we did that until I worked in peds. And you realize that you sometimes don't see the fracture. That's what you were alluding to earlier. Like you may not see the fracture, but if your patient has bony tenderness, a story that makes sense for a fracture, we're splinting those kids and sending them to orthopedics a week later. Just to be careful.
Yeah, I think that's a great point, because not every kid that comes in that has a fracture is going to show up with an x-ray where there's a clear fracture line. So even in my office, when I see a kid that's come to me, whether it's through the ER or from the pediatrician, if they have a story where they have fallen and they're hurting and they're limping or not weight bearing, I will treat it like a fracture. And the reason why is because kids that are growing, sometimes they can have an occult fracture that you don't see, but will eventually show up. Sometimes it takes 10 to 14 days. And what you ultimately see is a periosteal reaction, which is a response to a bony injury. So kids that are growing have something called a periosteum, which is this thick kind of covering around the bone that provides blood supply to the growing bone. And so sometimes you can have a fracture that's within the bone, but you can't see it, and it bleeds and it gets in between the periosteum. And what happens is in the periosteum, you have some of those kind of mesenchymal bone cells that will start to form bone to kind of bridge the gap. And so 10 to 14 days later, you'll see that on an x-ray. And so, and those kids, let's say they were in the ER 2 days ago and they were splinted, I'll see them and I won't even re-image them because at that point it's too soon. I won't see any periosteal reaction. I will take the splint down, do my exam, and if there's tenderness, then I'll treat it like a fracture. And that's what I tell the family, that I would rather them be mad at me for making their kid slow down and to put a cast on than to say it's probably going to be fine and then have them run and fall and turn a non-displaced fracture into one that needs to be either reduced or at worst have surgery. So I splint and cast things often. The majority of the time when there's tenderness and there's a story to back it up, you're right. And so you'll find that out when they come back, you re-image it and there's healing fracture. So I would err. I would not feel bad to put a splint on.
Yeah, if they're hurting, splint it. You kind of talked about follow-up. Our general rule of thumb is follow up with ortho in a week. And is this kind of lends to that, if you need to re-image them?
Yeah, I think that's great timing, because if it's a non-displaced fracture or something that doesn't need surgical intervention or something that hasn't been reduced, 1 week is fine, because I'm not going to re-image it any sooner than 1 week. And I don't want to waste people's time for certain things like distal radius fractures or even forearm fractures that have been reduced. I will often leave them in a splint for 2 weeks if it's in good condition, so it doesn't fall off in my office while I'm trying to transition them into a cast. So 1 week for certain fractures is perfect. And then depending on what it is, we kind of go from there. If it's been reduced, then I'll see it a week after that for a couple weeks, and then that's it.
Do you use some of these like removable splints that I hear about, the ones that kids can swim in and shower in or take off for bathing?
We have removable splints that we put on, and that's usually kind of further down the line from a reduction or once the swelling's gone down. So not acutely, but we have these things called exos braces, which are kind of a thermoplastic material that we warm up in a little heater in our office and then mold it and put it on the patient. For me, that's something I use either at the 4 to 6 week mark. But if you still need a cast, I do have waterproof casts that we can put on as well.
Okay, that's cool. I've heard about those things. So you kind of mold them. It's kind of a patient-specific thing. That's cool.
Mm-hmm. Yeah, the exos braces are.
So those are for kids that are, well into the healing cycle, but they're going to need splinting more long-term?
Well, so for me, it just depends. So my general rule of thumb, let's say for both bone forearm fractures that have been reduced, they're in a well-molded sugar tong splint. I keep that on for 2 weeks to 3 weeks. And then I put them in another long arm cast for 2 weeks. So they're going to be immobilized. Their elbow will be immobilized for at least 4 to 5 weeks. Then I will transition them to a short arm cast. And then I let them go into a brace after that. And they don't have to sleep in the brace, but they come out of the brace for wrist range of motion and forearm range of motion. And then to start using their arm to get supination and pronation, because they can get rather stiff. And those are important because forearm fractures sometimes can be bad actors, and they have a refracture rate of up to 10% in the first year. So, right, it's unreasonable to tell a family to wear a brace or a cast for a year, but I give them a brace in that initial period after 6 to 7 weeks, just to kind of limit any potential refractures until they get their range of motion.
So what do you tell these, if a parent asks you, what's the healing time for like a both bone forearm that's reduced in the ER, what would your answer be?
Yeah, so just about every fracture takes 6 to 8 weeks to heal.
Okay.
There are some variations in that, like intra-articular fractures, like lateral condyle fractures. They can take a little bit longer, any kind of intra-articular fracture. But in general, a both bone forearm fracture, a distal radius fracture, is going to heal in 6 to 8 weeks.
Okay.
That's whether or not you have surgery.
Oh, yeah.
Doing surgery doesn't make anything heal faster, just makes it heal where it's supposed to heal.
Okay. Let's move on to elbows. A lot to cover here. We kind of walked through a whole visit here with the forearm, so we're not going to do that for all the rest of these fractures, but let's just talk about the different types of elbow fractures, things we need to be worried about. Yeah.
So elbows are very challenging sometimes to folks that don't look at them every day. There are specific timings of growth centers and when those growth centers close in the growing child. So elbow fractures can be difficult because a lot of times, like a lateral condyle, the bone could be fractured, but the cartilage that doesn't appear on the x-ray, it could be extending into the cartilage. And so that just makes it kind of a challenge. So you've got lateral condyle fractures, you've got supracondylar fractures. Supracondylar fractures are the second most common type of fractures in kids, most common fracture in the elbow. And you have medial epicondyle fractures, and in younger kids, less than 3, you have transphyseal fractures, which can be associated with child abuse. And so there's all kinds of elbow fractures. Definitely the most common is supracondylar, probably after that, lateral condyle. And then you have elbow dislocations. So that brings up another thing that we didn't talk about earlier, but elbow dislocations in kids are kind of a big deal because after you put it back in place, you have to play a little game with yourself when you're looking at the x-ray, and that is to find the medial epicondyle. Because when you have an elbow dislocation, you can have a medial epicondyle avulsion, and sometimes after you reduce it, that medial epicondyle is incarcerated in the joint. So every time you reduce anything, it needs a post-reduction film. Anytime you reduce a dislocation, you need a post-reduction film. That can't be more important in the elbow because after you reduce an elbow dislocation, you have to make sure the medial epicondyle is not incarcerated in the joint. Because if it is, that person needs to go to surgery.
What are you looking for on the film?
The medial epicondyle.
But what would it look like if it was incarcerated?
So you need to get an AP and lateral and then obliques of the elbow. So an external rotation oblique will let you look at the medial side of the elbow as well. And so you need to get obliques so you can find it. And you should be able to see the medial epicondyle where it's supposed to be anatomically. If it's not there in an older kid, then you assume it's in the elbow joint.
So you're not going to appreciate this on exam. This is only something you're going to see on imaging.
They may have a lot of medial swelling and a lot of medial tenderness if they have a medial epicondyle fracture. So it's kind of hard because when they have an elbow dislocation, it's diffusely swollen and tender. And a lot of those kids really aren't the best historians when their elbow is dislocated, even post-reduction wise. But you can feel the medial epicondyle, and if there's a little bit of crepitus, you can suspect a medial epicondyle avulsion fracture.
Yeah, I mean, we're lucky. We have ortho at our fingertips. I just call and ortho shows up, and I don't really have to know some of this nuanced ortho stuff because we can call you. But if I was out in the boonies and I was wanting to make sure that it was okay, it would just be pain disproportionate to what you'd expect, or this imaging finding?
Well, wouldn't you say that if you're out in the boonies or you're at a clinic, if a kid has an elbow
You'd send it to
injury and swelling, you have no business taking care of them out
right.
there.
Yeah, I would think.
That was my thought. Yeah.
Yeah.
And it's the same even in the ER. I've gotten to the point now, even kids that just have that posterior fat pad on the x-ray, but have swelling in their elbow. I talk to ortho about all those kids. I mean, elbows are just, so much can go wrong. And number one, I'm not comfortable with that. Number two, you're right. It's at our fingertips. Why not make that little secure chat message to ortho? Like, hey,
absolutely,
this is what's going on. Can you peek at this?
Yeah.
But where you're talking about out in the community, put them in some plaster and send them down to the
PD. Yeah. Send them down so we can get a specialist to look at it. I like it. So tell us a little bit about which fractures in the elbow we need to be most concerned that are surgical versus non-surgical.
Yes. A lot of fractures in the elbow are surgical. Supracondylars can be surgical. Type 2 supracondylars. And so I don't want to get kind of bogged down in too much of our orthopedic jargon, but some type 1s and type 2s don't need necessarily surgery, but just need to be watched closely. All displaced supracondylars will need surgery. Lateral condyles are also kind of nuanced because the kid is growing and you can't see the intra-articular surface because it hasn't ossified yet. Then sometimes we just need to see it. So if you got a lateral condyle fracture and it's like a little bit displaced, then either transfer to us or call orthopedics, because sometimes they don't need anything, but sometimes they do. And if they're kind of 2 to 4 millimeters displaced, then a lot of times I will take them to the operating room and I'll do something called an arthrogram, where I'll inject saline and contrast into the elbow joint, because when you do that, then you can see the articular surface. And if there is no step off, then they will get a screw to hold it in place or some wires. If it's displaced, then I need to open the entire elbow joint to put the fracture back together and then stabilize it. So lateral condyles are really tricky because if it's displaced and it's in the joint, it may not heal at all because it's intra-articular. And so for me, if there is a patient in the ER that has one that I think needs surgery, it doesn't have to go that day or the next day, but sometimes in really unreliable families or people that maybe just don't have the best resources, I will fix those the next day because I don't want them to disappear. Because every now and then we'll get in our office someone who was lost to follow-up, and they'll have a lateral condyle fracture that did not heal, and it will be a huge surgery to reconstruct. Actually did that
recently, right?
2 or 3 weeks ago in a patient that hurt their arm. They disappeared for about 1.5 years and then had pain. And when they came back to see me, they had a really bad lateral condyle non-union that I had to do this really big operation on to stabilize. So lateral condyles, and supracondylars, if I fear the family will kind of get lost or will disappear, I will do those the next day.
Yeah. Correct me if I'm wrong. In my mind, like a Salter-Harris 1 is generally something I can splint and have follow-up outpatient. I don't need to be as worried in those patients. But when I'm getting up above that, that's when I'm definitely getting orthopedics to look at the film.
Yeah, I think it depends on the Salter-Harris 1 fracture.
Okay.
Because in the elbow, since we're talking about elbows, a physeal separation in a young kid is a Salter-Harris 1 fracture, but it is not like other types of Salter-Harris 1 fractures, like in the distal radius or fibula. So
maybe err on the side of caution, and if you've got somebody that can look at the film, have them review it.
Because Salter-Harris 1 fractures in the distal femur can be really bad too.
Okay. The thing that we all love in the ER, nursemaids' elbows. John, walk us through how that, what does that presentation look like? How do you manage it? I know you have like a suave way of doing this because we all do. So walk us through this visit. How do you decide I don't need a picture. I'm going to do this reduction. It's going to be a good day.
Yeah. So I think if the story matches 100%, and, it's the story of grandpa was holding their hand, they sat down all of a sudden, and they've been crying ever since that time, refusing to use their arm. Then I'll kind of put them in their caregiver's lap. I feel from clavicle all the way down the fingertips. And it kind of goes back to what we were talking about earlier. Because if I'm pushing anywhere and there's a fracture, almost always they pull away. Mm-hmm. With nursemaids, they don't do that. They just want you, if you hold their arm at their side, they'll let you push all over it. They just don't want you, supinating it. Is that proper English? Supinating it.
That's proper elbow. Tennessean English.
Yeah. And they don't typically want to raise up above their shoulder either.
It kind of hangs on their side usually.
That's right. And so once I've established the story matches and the presentation matches, and of course, if the kid has a history of a nursemaid's elbow and there's no swelling, no pain on palpation, I usually sneak up on them. I have mom or dad hold the other arm. And I personally, I know the book says supination, flexion. I have had the absolute best luck with hyperpronation.
I do both. I do hyperpronation and supinate. So a little combination of everything. Do you tell the parents you're going to do it before you do it?
I do.
Okay. Yeah, I do too.
They don't like you torquing on their kid's arm and they don't understand why.
Yeah.
But when you tell them, hey, this is an instant fix if we do this right, they're usually okay with it.
Yeah, I kind of walk in when the story fits and I'm thinking it's going to be one. I usually tell them, I'm going to examine your child. And if I don't feel anything that makes me worried for a fracture, I'm just going to roll right into this reduction. Yeah. And your kid might scream for a minute, but it's going to be over and they're going to feel a lot better.
That's right. The trust factor is big right there with a parent. Let's get away from that real quick. But, sneaking up on people, like in teenagers with dislocated fingers, I found if you try to reason with a teenager and a dislocated finger, you'll never get it.
I know, you'll be there all day.
I walk up, hey, let me just see what's going on. And I usually just pop it back.
Same. Yes. No discussion. We all love to reduce a nursemaid's elbow for sure. All right. You wanted to talk about Montaggia fractures in this vein.
Yes. So as an orthopedic surgeon that sees these in my elbow fractures in the office, Montaggia fractures are really important fractures that need to be addressed, because a Montaggia fracture is some form of an ulna fracture with a dislocated radial head. More so than other types of elbow fractures, these can get missed because certain kids that are really young can get an ulna fracture that is not necessarily displaced. Really, it's just bent. And in orthopedics, we call that plastic deformation. So you can kind of bend the ulna and it will make the radial head pop out. So these kids will have limited range of motion in their elbow. They'll have elbow pain, forearm pain. And sometimes you just want to get a forearm x-ray, but that's why we always image things kind of above and below in orthopedics, because if you miss a Montaggia fracture and the patient doesn't follow up and the radial head is out for 3 weeks or more, then that patient may need a very large surgery and potentially a ligament reconstruction because the radial head has been dislocated the whole time. So just something to do in particular when you're looking at elbow films is in every view, when you're looking at the radial head, if you draw a line down the radius through the middle of the radial head, it should always point at the capitellum, whether it's an oblique, whether it's an AP or a lateral. And so if you've got a forearm injury, get an elbow film as well, because you'll see some kind of Montaggia fracture if it's there.
Yeah, great advice. That's not something I routinely do. Do you do that, John?
I was going to ask him that because I feel like the residents more than ever are asking us to do films of other areas that in the past, if it was a simple distal radius fracture in the past, like that's good.
We didn't get elbow
just
films.
Splint it or be down to fix it. Now they're like, can you get that elbow joint, please?
Yeah. Do you think, I mean, I can't say that I routinely on every forearm fracture get an elbow film. I did know about looking for this, the radial head alignment. I learned that, in school. I found a really awesome PowerPoint on orthopedics made by Dr. Stuart Braden. He's out of, an emergency medicine doctor out of the University of Michigan. I'm going to add it to the show notes today, mainly because he includes so much imaging, and he actually talks about this, and he shows that alignment that you're supposed to be looking for. So that'll give you a good visual reference on what we're talking about with regard to the radial head, lining up in your elbow films.
What is a Galeazzi fracture? I remember there's always Montaggia.
Yeah, so a Galeazzi fracture is like a kind of a distal third radial shaft fracture with a disruption of what's called the DRUJ, the distal radial ulnar joint. And so that is a Galeazzi fracture, which in kids doesn't happen a lot. I can't say if I remember that I've really seen one in a kid. It happens in adults more so than the pediatric population.
Yeah, I've never seen that in a kid. I think I saw it once in an adult. But I didn't spend years and years in adults, thank goodness. Okay, let's finish up upper extremity and talk just a little bit about clavicle fractures. We see these all the time, super common in children. Another thing I learned when I came to peds is that, when you do a really good exam of the upper extremity, really check the clavicle, because oftentimes when they fall out of bed or fall over, they'll break that clavicle first. We image these, and our general recommendations, John, are what?
I've always been told that very rarely do you need to do anything other than put them in a sling, ice packs, ibuprofen or Tylenol, and follow up in 3 or 4 weeks.
I see them in a week or two. I'll see them in a week or two. If I see them in a week, I won't re-image them. If I see them at 2 weeks, I'll re-image them.
Oh, would you prefer to see them at 2 weeks?
I think sometimes that just depends on the family, because some families, you're going to tell them that they have a fracture, and when you tell them 2 weeks, they're going to get upset. And so if they are really kind of questioning you and they're not happy with that, a week is fine.
Okay.
And then I tell them, I'm not going to re-image it. At this point, I'll see you in a week or two. And the reason why I do that is because my kind of treatment algorithm for clavicle fractures is I put them in a sling for 2 weeks. At the 2-week mark, the fracture has healed enough that I let them discontinue the sling and start gentle shoulder range of motion. Nothing overhead yet, but I don't want them to get a lot of elbow stiffness, because some kids will just stay in the sling indefinitely, and then when they come back, they've got a healed clavicle fracture and a really stiff elbow. So at 2 weeks, I discontinue the sling and I let them gentle shoulder range of motion. Now, sometimes in boys, I'll tell them to wear the sling to school, because that reminds them that they've got to take it easy, and it reminds their buddies, like, maybe don't tackle him because he's still recovering. So and some of the kids, I tell them to wear the sling at school, but when they're at home, I want them to come out of it. And 2 weeks is my kind of timeline for that.
But initially, it's fine for us to send them in a splint and not necessarily have them doing any range of motion exercises?
The sling.
Just the sling, yeah, that's it.
Okay.
Do you remember the medieval torture devices we used to put?
I was going to say figure eights are gone, right? That's
such a horrible device. I'm so glad that we can just sling these kids now.
Kind of a crazy thing. They still sell them online to improve your posture, which seems so crazy.
So I remember an orthopedist telling me a long time ago on a pediatric, I think he'd said below 10 maybe, pediatric clavicle fracture, if you can see both ends of the fracture on the x-ray, they're not going to need surgery. And I guess that's because of their growth plates. And I mean, I know this exaggeration, but basically he was saying, man, in the ER, just put them in a sling no matter what you see if it's a kid below 10 with a clavicle fracture.
Yeah, and that generally the only exception to this is if they have tenting of the skin in the emergency department, right?
Yes, if they have kind of an impending open fracture because the skin is like tented and it's hyperemic and white and not perfused because it's displaced that much, those kids may need to have surgery, because if you leave it, it may just come through the skin. But the majority of them, by and large, do not. And even if you palpate them, as long as the skin is perfused, there's no wound, they will do fine without surgery. So there's a big kind of area of contention in clavicles. For kids, we used to fix them a lot. Some over the last 10 years, there's been a big uptick in the amount of clavicles being fixed, but now we're starting to realize that in kids younger than 18 that are still growing, then you don't necessarily have to, even if they're 100% displaced, because they will heal. The clavicle is an interesting bone. It's the very last bone in the body to have its growth centers fuse. So it's the last bone to stop growing, essentially. So clavicle fractures remodel well. And I rarely ever fix them because they do well, and they have a relatively very small non-union rate, maybe less than 1%. Adults with displaced fractures, that's not the case, but a recent data that we have shows that kids even younger than 18 with clavicle fractures that are displaced, they do well non-operatively, and some of them actually go back to doing stuff a little bit faster than if they had surgery.
Even when they're incredibly angulated, like some of these look really impressive on film, and parents are like, wow, you're not going to fix that? That's insane.
Yeah. That's, it sounds crazy to say. And it's kind of funny that you say that, because oftentimes in my office, some of the longest and hardest conversations that I have are explaining to families why we don't need surgery.
Yeah.
Which is counterintuitive to me when I thought about becoming an orthopedic surgeon, but those conversations can be very difficult, explaining to families why they don't need surgery. But clavicles do well. I've been in Chattanooga for a year and a half. I fixed one clavicle, and the family was insistent. And so I fixed it.
Okay. We hear rumors in the ER. We don't, really know what's going on with ortho, but we hear occasionally that, they're fixing more. I had heard at one point for an older kid that was maybe like wanted to be involved in sports or like had an athletic career ahead, that maybe this is somebody we should send for possible surgical intervention, but really no.
Yeah. Even some of the like bigger kids that are playing sports. Yeah. I don't necessarily change just because they're going to be an athlete.
Okay. Hey, PemChat listeners, thank you so much for being with us here today to talk about common pediatric orthopedic emergencies with my favorite ortho bros, John Appel and Dr. Chuck Gomez. It ended up being a pretty lengthy recording when we got done, and so I've decided to break it in half into 2 segments just to make it a little bit more digestible for the podcast format. So you'll notice that today we finished up with our emergencies affecting the upper body. And when we get back next month, we're going to finish up this podcast with the second segment in which we talk about emergencies that affect the lower body. So join us next month when Dr. Gomez and John will be back, and we'll finish up this podcast on orthopedic emergencies. Thanks for being here. Have a great day.